So, welcome to this edition of the Cataract Specialist. And this evening, I've got the absolute delight of talking to a very old friend of mine, Jonathan Ross from Edinburgh, who needs no introduction to many of you. Jonathan is a great force for good in Scottish and actually UK ophthalmology in general, having set up Vision Scotland in 2013. A couple of years ago, he was rated by the Fin Network as the busiest private cataract surgeon in the entire UK. And we've got lots to learn from him. John, welcome. And for the benefit of those of you who don't know much about you, could you just tell us a little bit about yourself?
Sure. Yes. Thank you, Simon, for that embarrassing introduction. And um, uh, I'll try and move on from it as quickly as I can, actually. So I went to medical school in Glasgow from 93 to 98. Immediately joined ophthalmology. I was actually offered a job right at the beginning in what was a prestigious sort of run-through training program in neurosurgery in the Edinburgh one. And I turned it down to do a 1 year standalone SHO job in ophthalmology in a backwater called Hereford, which you might have heard of.
I
Uh,
have.
you have heard of that? Oh, excellent. Yes, I thought you might have actually. And Of course, the Edinburgh guys were horrified, but I really did want to get behind the slit lamp, and I was very excited about that. And Hereford turned out to be one of the most incredible job opportunities I've ever had. Really, it was wonderful. Um, Learned all of the basics of ophthalmology, learned cataract surgery, which I loved. And after that, I did the part one. I think it was part one back then, probably is now. And then went on to do the rest of my training in Liverpool for the SHO training, and then in Glasgow for the registrar training. And then I did a fellowship actually in orbital and ocular plastic surgery. So in the plastics and burns unit in East Grinstead in London, in South London, which was an 18-month fellowship, which was a really steep learning curve. And actually, on reflection, I went into that fellowship probably quite an inexperienced surgeon, and I think I came out far more experienced in terms of my ability to run a service and do some reasonable surgery as well. I then went off and worked, and this is probably the best part of my career in some ways, actually. I took a complete curveball opportunity and went out to work in New Zealand, running an entire department, which had kind of collapsed. Someone had retired and someone had gone off somewhere else and stuff. So there was no one left. And I worked really hard to fix that department, and I was deemed to have done a good job of it. So the sort of public hospitals, the NHS in New Zealand, the management structure there were very dynamic, which you'll be able to relate to with the NHS you work in, and they put me straight in touch with the Department of Health in Wellington, and then I started working with the Ministry of Health and working to fix other departments, and that was really good. I also worked with Professor Multino for a while, who obviously the father of the Multino valve. So I did an awful lot of complex glaucoma surgery while I was out there. Um, uh, and then I came back to Scotland. We wanted to return home for family reasons, actually. Uh, Took the job in Edinburgh, and started to build a life there. Really, very enjoyable. Worked in the NHS for 6 years in my first job. Took it as far as I could. Really, I mean, for me, I like to I like to do something a bit different every year and see kind of things changing. And I thought after 6 years in that role, I probably had I gone as far as I could in terms of moving the department forward and so on. So I then took, but just interrupt me if I'm going on too long. That would be absolutely fine. But I took a second NHS consultant job in Glasgow for a while, which was high volume surgery. And
I
again,
think the
very enjoyable.
aspect that most people are going to be really interested in is your Vision Scotland work. Tell us a
Well,
little bit
well,
about that.
yes, but I mean, yes, of course, we're coming to that as well. So during that time, I started to see the way that I wanted to run an ophthalmology service was just not really going to fit into the public sector. It wasn't. I wanted to have no waiting times. I wanted to be able to give the patients a much sort of higher quality journey, more time with each person and greater choice of lens implants and and so on and so forth, and also better communication and direct access to somebody 24/7 and all this sort of stuff. So it just became obvious that I had to do things myself because there was nowhere around that region that's offered what I wanted to do. I didn't know how to achieve that, I'll be honest with you. I talked to a number of colleagues, and the one colleague who seemed to buy into my poorly explained vision at the time was Sanjay Mantri in Glasgow. He obviously got where I was coming from, and we decided to join private practices and try and build something that was bigger than the sum of its parts, effectively. And that would have been about 2013, 2014. So we're talking about more than 10 years ago now. And well, there's a lot of stories between then and now, but it's fair to say that it's done that and some.
Very good indeed. And if you weren't an ophthalmologist, what job do
Hmm.
you think you'd be suspiciously good at instead?
Well, the honest answer is probably nothing. Uh, but if what would I like to do? So I did do a video about this on on for like social media a while ago. So I get regularly teased by patients who've researched me. They asked me to sing during surgery and stuff because I said that I would love to be a West End on the West End stage in a musical production. And as you know, I would be terrible at that. But the enthusiasm and the ambition is still there. So there would be that. And I'm now kind of quite involved in the world of finance and venture capital and private equity. And I think the intellectual learning curve of understanding global debt markets and finance has actually been, for me, actually quite interesting and just very different from what I've known my whole career. So maybe something in that world would appeal. You're probably asking, what other kind of doctor would I like to be?
Not necessarily, no.
Because that's what people usually ask. But I think if I wasn't an ophthalmologist, I don't think I would do any other subspecialty. I think ophthalmology is undoubtedly the best branch of medicine to be involved in.
Yeah. Turning to cataract surgery now, are there any parts of cataract surgery these days where you still hold your breath, even after doing tens of thousands of cases?
Probably lots, actually. I mean, honestly, nothing's happened recently, but um, I do remember doing a case. It was one of these sort of Swiss cheese models where everything lines up, and you've got a patient who's super anxious, a difficult personality. They're a really difficult personality. They've got an axial length of about 12 millimeters, um, and they've got an ACD of about zero point 0.8 millimeters, and but they've got a dense cataract, right? So what are you going to do? You're going to just leave them, or so you decide to operate on them. Everything's going kind of well, and then lo and behold, the AC collapses and you can't really inflate it, and you're battling away with the remaining soft lens matter, and you knowing that if you can't get this done, you're going to have to bail out and go back to them another time, bearing in mind their personality and all the rest of it, and the sweat's just pouring down you, and it's like sort of 9 o'clock at night, and you've already done 69 cases, and and obviously I'm painting a picture here, but there are certain situations you get into in life where you think, why, why did I get involved in this situation? This is not good for me.
It's nice to know you're still human. So, what do you think it is that leads you to stand out from the crowd and achieve great results? Because I think you are nationally renowned these days.
Nationally renowned for what? I
Just
dread
remember,
to
this
ask.
is a PG-rated podcast.
Nationally, I don't know what I'm renowned for nationally. I generally don't. I mean, I think, yeah. Sorry, you have to explain more. What's the question here?
Is there anything in particular that you do, cataract surgery wise, that leads you to get great results? Do you do anything
Well,
differently from anybody else?
um, Well, I mean, I've done about 30,000 operations, and in that process, I've become quite good at doing it without any problems. So the complication rate's very low. And I have a philosophy that I don't think, a lot of surgeons I've seen don't have the same kind of approach whereby you're thinking about the concept is um, dispensing no energy inside the eye. So, you have the microscope on the lowest possible light setting. You aim to physically manipulate the eye as little as possible. You mm, um you make sure that your blades are super sharp, and so you go in and out with the least trauma. Um, when you're doing your rexis and when you're doing your grooving and stuff, you really take time to make sure that there is absolutely no movement on the zonules. So you're really keeping things super still. And by being experienced, you can be reasonably quick. And I mean, quick to be not spending any more time in the eye than you need to, rather than being quick as in recklessly quick. Um, and we've got a great setup, and we've really optimized our biometry. We don't restrict ourselves to any lens manufacturer. We try to genuinely tailor lenses to people's needs. And there's a great team and a process wrapped around that, so that he doesn't even have to rely on me. There are people that know that stuff better than I do, who are not doctors within the company. Um, uh, and we kind of micromanage the aftercare as well, I guess. So there's not one thing in there, but you get great results by doing everything a little bit better than other people are doing it if you can, and then you combine all that.
Absolutely. A combination of teamwork leading to dream work and the sky cycling team analogy as well of tiny
Yeah.
marginal gains, isn't it? So
Yeah.
if you could give one tip to more junior surgeons about cataract surgery, just one tip, what would it be?
Uh, well, I suppose the one tip would be do as much surgery as you can,
Mm.
because you can't get good but without experience. Could I have two tips?
Yes. Why not?
Okay.
Yeah.
So do as much surgery as you can, and then secondly, try to develop a lifelong mindset that there's always scope to get better. Don't ever think. I think a lot of surgeons secretly get to a point where they think, I'm good. I'm happy being this good.
Mhm.
I'm going to keep going at this. Try never to have that. Try to always be a little bit uncomfortable, you know, and never get to the point where you're just comfortable doing what you're doing, but feeling that you always need to improve and be a bit better, and just be hungry for any gains you can get.
Now, I've got an inkling as to your answer to this next question from a previous chat we've had, but what single innovation do you think is genuinely going to transform UK private cataract surgery in the next decade?
What single innovation?
Yeah. Any new machines, any
Oh,
new techniques, any new drugs?
well, we were talking earlier about a diagnostic piece of equipment. Is that might be part of it, but I think that will. I mean, the lenses are going to get better. They're going to keep improving. They're already really good, so there's going to be no like seismic changes, but there's going to be ongoing refinements. And I think AI, we know now that AI can look at massive data on optical physics and outcomes, and actually make recommendations about what the perfect opportunity is.
Yeah.
I think we've seen that already with one lens, and I think we'll see it with more. I think that um, we will get better at guaranteeing exact refractive outcomes. I think that would be a big game changer. And I think that the thing we were talking about earlier I think there are new diagnostics coming onto the market, which they're not simulations, they are actual real life opportunities for patients to neutralize their natural lens, sit at a machine, and then look through a machine which has got a lens implant in its housing, and to look through a trifocal and see the world through a trifocal as you would as if it were in your eye. I know that sounds a bit sci-fi, but It really isn't. It's here now. I've actually sat on one of these machines myself, experienced near and distance vision, experienced day and night vision through these, and then really just pick that lens out and put in a different trifocal and another trifocal. So there's going to be an opportunity for patients to tell the surgeon which lens they want based on what actually looks best through the neural networking of their brain and their eyes.
Mm.
And that's going to be a really, that's going to really democratize the lens because the lens manufacturers will be, they'll be held to the fire. And if their lens isn't as good as the other ones, there'll be no more hiding behind data or anything. There really won't. And that will come out. So that will be a big change. Um,
Will really empower patients, won't it?
it's huge empowerment. Yeah. And it's great. And like, let them choose. Absolutely let them choose because they could live with it for the rest of their life. Yeah.
Do you foresee a future in your professional lifetime where cataract surgery will become fully robotic?
Um, no, I don't. But I'm very old and I've not got long to go. Um, the
Almost deep fat pride Mars bar, doesn't it, John?
well, the Scottish lifestyle that does have its enjoyments and its drawbacks. So let's just accept that. But I mean, the thing about that question is that people sort of frame it as, in the future, will AI take over? And it's actually a completely meaningless question because in order for it to have meaning, you have to sort of say, will AI take over in 20 years? Will it take over in 50? No, because if you say, will AI take over these things in 10,000 years? Well, yeah, of course it will.
I know.
And
Your professional lifetime is much shorter than that, I was hoping.
right, right. So I don't, right. So at some point, robotics and AI will do stuff not just as well as us, but like a million times better than us. And they'll keep improving. Or 10,000, whatever it is. They'll be so much better that culture will shift towards accepting that it's really quite unsafe to let a human being anywhere near your eye.
Absolutely right. It
Right.
was really a question about timescale.
But the timescale for that is not in my lifetime. No, it's not in the next generation. It's probably 100 to 200 years from now. I think.
Okay, let's change tack. What are your views on bilateral same-day cataract surgery?
Um, I sat on the committee, the Ukiscus Royal College Joint Committee during lockdown, where this really came into sharp relief because we were, as you know, it was the first time ever that the UK and beyond had a sort of a complete outage of private and publicly funded provision of elective healthcare. We don't think that's ever, when did that last happen? I don't know, maybe during the World War or the last World War or something. But that happened and the waiting list went up and up and up and up. And then people were having a much more serious conversation about how we can work efficiently and get more done when it starts up again. That conversation was going back a good few years before that, but it wasn't gaining as much traction as it should have done. I mean, the science was there to say it's safe to do, but culture and probably fear of rare bad events happening were dominating the conversation rather than science and data, which is often the case. But during that period, that I think that balance flipped because people were just more worried about getting work done and people just sitting going blind at home, and so on. So coming out of lockdown, it went from being a niche activity to being a much more mainstream activity, and I think it gathered momentum. Um, I would say actually that way before lockdown happened, back in around about 2015, maybe, I started doing it in the hospital I was working in. It was fine. I researched the data on it. I didn't see anything to concern me. I had no problems, but I was making other surgeons feel uncomfortable who weren't sure about it, and that led to management feeling uncomfortable and me being asked to stop. So I was actually I wasn't doing it by 2020 when we had the lockdown, but I had done it in the past. I was comfortable with it. It then became much more mainstream, as you know, and I think really just got to a point both in the UK and abroad where the floodgates had opened and there was no going back. And so in Vision Scotland now, we do literally 70 to 75% to 80% of our patients as bilateral cases. I think I think Optegra do the similar, from what I understand. I can't confirm that. And I think another number of other very high volume providers do same day bilateral as their standard procedure. But there is still pockets of resistance and people who are unsure about it. I think that will gradually change over the next 10 years.
On a similar vein, what are your views on so-called dropless cataract surgery? In other words, no eye drops afterwards.
Um, I don't have really any strong views in that. Um, I think that, are we talking about like no drops at all, or are we talking about no antibiotic drops particularly?
Steroid injections at the time of surgery, meaning no postoperative steroid drops.
Okay, I mean, choose choose your preference. If you fill the anterior chamber with cefuroxime, we know you don't really need postoperative chloramphenicol drops or topical drops for that. Um, if you use a depot of steroids, that's fine. It works. It works well. You've obviously got a little bit more risk of stubborn pressure problems than if you use drops. So I'd I'd maybe
It's
challenge.
it's not an integral part of your practice at the moment, in other words, then.
No, no, we don't. We give a standard regime actually. Um, Partly to me, I think patient expectations as much as anything else. I think the steroids definitely do help. I think the antibiotics don't. And maybe we've been so busy building out our ophthalmology platform in the last few years, we haven't. That's one thing we just haven't kind of put under the microscope. But I guess we will at some point.
Which is the aspect of eye surgery that the public perhaps understands the least from your perspective?
Understands the least. Hmm.
A lot of
No.
patients think they have to wait, don't they, until they can have their cataracts done, as an example. Just wondering what your
Okay. Yeah. Well, that's yeah. We can. That's a great one to pick up on. That really is. Yeah. There's a national perception in the public that you're better to wait until cataracts are ripe before you have. Ripe is often the word that comes up. In other words, you're really struggling with your vision, and then if you don't come with really ripe cataracts, then you'll be sent away to wait until they are much worse before you are referred back again. Um, and of course, that's bad advice, isn't it? That's really bad advice for lots of reasons. Let's can we have we got time to go through those reasons? Is
yeah,
that
of
it?
course, of course.
Yeah. So we know that in the elderly, declining vision is dangerous. We know that it's associated um, with an increased risk of falls, and that leads to an increased risk of lower limb fractures and therefore hospitalization, and therefore poor mobilization afterwards, hospital-acquired infections, and actually early death. We know that it leads to a loss of confidence, and that leads to people spending more time at home, and so it leads to social isolation, which is bad for you. And actually, isolation, believe it or not, can cause Charles-Bonnet syndrome. Um, we know that it disturbs your circadian rhythm. So if you haven't got the right kind of light coming through your eyes to your brain, as a result of cataracts, then you don't get the normal circadian cycle. So you tend to be more awake at night time and more drowsy during the day, which impairs your performance, and it leads and that combined with reduced vision increases the risk of depression in elderly people. We also know that if you develop cataracts and you have dementia, it accelerates the dementia, it makes it go faster. And we know that if you have dementia and you get your cataracts treated, it can actually improve your dementia symptoms. Um, and there are probably more reasons besides. So, oh yes, of course. The other thing about advanced cataracts is that they're harder to remove safely. You have to disperse more ultrasound energy inside the eye to cut them up. Um, they are associated, on average, with slightly weaker zonules, longer phaco time, and therefore higher. And we know that there's data on this now. Actually, the mature cataracts versus mild cataracts, the posterior cataract tear rate is 10 times higher. The chances of corneal edema and descemet folds and CMOs higher, pressure problems and uveitis. Oh yeah, and also barometry. Our barometry machines don't measure the eye as well with mature cataracts, and therefore you get a higher chance of inaccuracies with your lens choice. So there are lots of reasons for not doing waiting until your cataracts are bad, but people still get advised to wait till they're bad. Um, and I guess the question then becomes why? Why do we, as a healthcare profession, I mean, why would we tell anybody to wait until any medical condition is really bad before you get it treated? There aren't any, I don't think. Um, Simon, you and I have discussed this in the past, and we think that it may come down to things like um, historically cataracts were a lot more risky to do, and therefore the risk benefit ratio was different a generation ago. And it was better to wait if they were a bit worse because the outcomes were worse and the complication rate was higher. Therefore, you need to have a bigger gain from a more advanced cataract to justify that surgical intervention. Don't think that equation is like that now, but it was, and it does take time for attitudes to change. And we also think there may be an element of with big NHS waiting lists, people are doctors are maybe put under a bit of pressure not to put patients on in the first place. That's probably more a factor in the Scottish system than it is in the English system these days, but it's something which is talked about. So there's a great opener for you.
So the bottom line is that if someone's got a cataract in Scotland, they should insist on a referral to Vision Scotland without delay.
I mean, I couldn't have put it better myself, to be honest.
Okay, so John, two more questions. If you had to have cataract surgery yourself tomorrow, here we are in 2025, which
Mhm.
lens would you choose to have inserted and why?
Well, I would first of all say that I'm not a paid consultant for any company,
Good.
so I can give you an honest answer. And the honest answer is I would wait till that machine comes out that allows me to look through all of them and then probably decide because I think it's coming out in the next few months. But if I didn't have access to that machine, um, I would probably go for This is a really hard question to answer, actually. I've had laser eye surgery, so that has a big bearing on my decision. That there are some lenses that would probably. So I naturally have. I don't know if you can see it, but I have naturally very big pupils of about 8 or 9 millimeters.
Very attractive.
Very attractive, but I can't look at my eyes and you at the same time. But perhaps you can get a sense of that. They're usually very big. And that, of course, is affects the optical zone. I've had laser eye surgery, so um, at least the theory, if not the practice, would tell you that I might not be suitable for premium lenses like trifocals and so on. Um, so maybe I would go for an EDOF with mini mono. I've also got monovision already. So I've got a distant dominant eye and a near dominant eye, and I'm comfortable with that. So maybe for me, a bit of mini monovision with an EDOF might be the best choice. But it always has to be tailored to the individual patient, and I haven't thought about it beyond that. I don't have cataracts yet either.
That's good to hear. Very sensible advice as well. And finally, if you had to have cataract surgery tomorrow, who would you choose to be your surgeon and what makes them the one?
That is the easiest question you've asked me all day. I've done my research, I've talked to all the patients, and I can confirm that there is no doubt at all that I would choose yourself, Simon.
And what about an affordable option, Jonathan?
No, I would save up. I would save up.
No, come on now. There must be someone closer to home.
I mean, I would take out your interest-free credit option, which is very attractive, and I would save up and I would come to you. If I had to go close to home, um, well, I suppose I'd have to be honest with you and say that my mother and my father and my auntie have all been operated on by my business partner and have all had excellent results, and that's Sanjay Mantri. So, um, I don't know if you'd agree to operate on me, mind you. That would be a whole different question. But
That's a
I'd
question
probably
I'll
go.
pose to him another time. Well, fantastic, Jonathan. Thank you so much for spending the last half hour discussing cataracts, and I've really enjoyed
Pleasure.
it. I hope you have too. Thanks
I
so
certainly
much.
thank you so much. Thanks again.
Take care.
Cheers now.